Sí, ahí está. Y pues bueno, en la sala tenemos a Irving. Con Irving lo que pasó ayer fue panuelo.
So welcome everybody. Good afternoon, good evening, and good morning, whatever you are in the world. Today we are going to talk about something very, very special. It's about genetics on our cardiac patients. We have a very nice experts here to talk to us. And I'm sure this is going to be very, very important to all of us to understand better our patients. So just before we start, to talk a little bit about our academy and the activities that we're planning for the next couple of weeks. So we invite all of you for our big sessions, for the big webinars that we have, the master classes, every Thursday at 3 p.m. Rome time. So exactly this time, whatever you are in the world. So this next Thursday is going to be cardiac anesthesia. The next one, ECMO part 1. The next one, interventions. And the next one, we are going to continue the TGA talk that we had last week. And then again, the second part of ECMO. If you were not able to see the TGA part 1, it was amazing, as well as a heterotaxy syndrome webinar and the hypoplastic left heart syndrome webinar. They are all on our YouTube channel. We invite you, all of you, to take your time and take a look. We have other activities as well. On June the 15th, next Monday, Dr. Silverman is going to have a very interesting classroom about the relationship of the morphology and the images for the truncus pathology. So it's going to be very interesting. He has amazing images. And then on the 16th, we are going to have a multicentric CICU response for COVID that is chaired by Children's National in Washington, D.C. And we are going to be happy to, if all of you can attend as well. It has been very nice, this collaboration of all the CICUs. And the next Friday, we have a classroom of Dr. who is going to talk about morphology of AST. So just to reinforce, our next activity after this one is going to be the cardiac anesthesia. This is important for you to know that it's not only for anesthesiologists. All the multidisciplinary team is welcome and invited to join us on this activity. And this is about the Dr. Silverman classroom. It's going to be very, very nice. The multicentric CICU response for COVID, that is going to be very interesting as well. It's going to be on the 16th. And if you think this is a nice thing that we are doing and you want to get closer to us, especially if your country is not already highlighted in red, please send us an email. We wanted to have delegates from all over the world that do help us to spread the news and to get the information wherever it's needed. So today we are going to talk about cardiogenetics, and this is very nice to know that as everybody was, a lot of people were interested in this subject. We are planning to have cardiogenetics part 2 soon, and we will let you know. Follow us on social media, Twitter and Instagram and Facebook and LinkedIn, so you're going to get information about all the events and activities that we are planning. So for now, thank you very much again. And I want to introduce Dr. Daniela Poli. She is a pediatric cardiologist in Bambino Gesù of Taormina, and she's responsible for the step-down unit. She's going to be our moderator of the session. Thank you very much, everybody.
Good afternoon, dear colleagues. I'm very proud to present this interesting webinar on clinical cardiogenetics, myths and truths. Our understanding of the role of genetics in the pathogenesis of congenital heart diseases has advanced at a rapid pace over the past 10 to 15 years. The availability of new molecular techniques has facilitated gene discoveries that have changed the medical and cardiological care of many individuals with congenital heart diseases.
Okay.
Cardiovascular genetics.
So welcome everybody. Good afternoon, good evening, and good morning, wherever you are in the world. Today we are going to talk about something very, very special. It's about genetics on our cardiac patients. We have a very nice experts here to talk to us. And I'm sure this is going to be very, very important to all of us to understand better our patients. So just before we start, to talk a little bit about our academy and the activities that we're planning for the next couple of weeks. So we invite all of you for our big session for the
I don't know why it happens again. No idea.
Thursday, 3 p.m. Rome time.
It's a loop of the audio that happened on the other meeting. So now it's stopped. Good. I'm sorry.
Thank you.
The next one, ECMO part 1. The next one, interventions. And the next one, we are going to continue the TJ talk that we had last week. And then again, the second part of ECMO. If you were not able to see TJ part 1, it was amazing, as well as an heterotaxy syndrome webinar and the hypoplastic left heart syndrome webinar. They are all on our YouTube.
Okay. Cardiovascular genetics clinics are now available in many major medical centers in the United States. Accurate diagnosis of congenital heart diseases pathogenesis is allowing for determination of familial reoccurrence risks, providing reproductive options, identifying extracardiac manifestation of the genetic diagnosis that could affect the clinical care, and improving long-term medical decision in the care of congenital heart diseases. Now the presentation will be started by Dr. Baban, Cardiogenetic Service, Medical and Surgical Department of Pediatric Cardiology, Bambino Gesù Hospital and Research Institute.
Okay. Well, hello everyone. Do you hear me? Is it okay? Okay.
Perfetto.
Okay, thank you. Well, I would like to thank first the organizers, Grace, Sasha, and Daniela for giving us the chance to present part of our work. We are very happy with this experience. So I'm going just to check. So I'm going just to try to give some information that are most useful, let's call for clinicians, and there's nothing to disclose. So rare disease patients face common problems. Why? Because often we have a lack for the correct diagnosis. I mean, in this case, for congenital heart defects, the comprehensive diagnosis, the multi-organ diagnosis, and often there is a delay in diagnosis, and the quality of information often it is also lacking, or it is few. And lack of scientific knowledge, and of course, in that case, there will be heavy social consequences for patients. In addition, unfortunately, often we find some inequalities and difficulties in access to treatment and care. So one of the main problems is that patients with rare diseases, they have a delay in the diagnosis, and sometimes the time can be even not months, but sometimes years also, until you can find the diagnosis. For example, in DMD patients, or even in patients with Prader-Willi syndrome, there might be years or even months or years until you get the diagnosis. In this map, there's a very particular information, because here you can see the percentage of rare diseases that get diagnosed by the parents of the patient or by the relatives of the patient, because in that case, patients, they go to local health or to pediatrician, and then they don't get the diagnosis, and then one of the parents, they go and study, and they make the diagnosis for their children. So it's not so easy for rare diseases to get diagnosed. And for rare diseases, there are different patterns of inheritance. It can be an autosomal, can be mitochondrial, it can be X-linked, or it can be recessive, or it can be simply sporadic. So when we talk about rare cardiac diseases, it can be subclassified into major groups: inherited cardiac diseases, congenital heart defects, and other rare forms. The inherited cardiac diseases are the cardiomyopathies and electrical diseases, mainly included in the European Reference Network, and hopefully in the coming call, the congenital heart defects will be taken in consideration both for children and both for good. Now we're going to talk about the congenital heart diseases, and please, for the surgeons, don't be freaked out with this picture, because you can notice that the heart is formed from the interaction of many factors that can be from many genes, that can be transcription factors, they can be sarcomeric genes, and so it's not so easy and linear always to make the diagnosis. But just to get the idea, what we need in the first glance when we see a patient with a congenital heart disease, we need to understand if this is an isolated or a syndromic case. Is this a sporadic or a familial condition? Hopefully, the majority of congenital heart diseases, they are isolated. However, this depends on which part of the world we are seeing the patients, because, for example, high inbreeding or consanguinity, they can increase the complex forms. The syndromic patients, they represent almost 1/3 of these patients, and there are more than hundreds of different diagnoses and syndromes. Sometimes we get the hint, sometimes it's the heart that helps us to make the diagnosis. For example, we know very well when we see a patient with a pulmonary stenosis, especially with a supravalvular pulmonary stenosis, we think of Noonan syndrome. When we see left-sided lesions, we think of Turner or Kabuki. When we see patients with tetralogy of Fallot or truncus or interruption of the aortic arch, we think of microdeletion of 22. And when we see the canal, the atrioventricular canal, we think of Down syndrome or Alzheimer's revolt. So sometimes the heart helps us, the type of the congenital heart defects, it helps us to make the diagnosis. And why is it important? Because 10% of all pediatric mortalities are due to congenital heart defects. And 50% of death secondary to malformations are due to congenital heart defects. And it has still has a relatively high frequency. So the causes can be genetic causes, or it can be non-genetic ones. And never to forget the multifactorial. The multifactorial means that we have different genetic factors that can interact with environmental factors to cause the phenotype. And in the last years, it's always more and more emerging the effect of epigenetics that needs maybe another presentation just to start and try to explain what we know about it. So here I'm going just to talk about I will start with the chromosomal defects that we see in patients, in the patients that has congenital heart defects. Those with trisomy 21, trisomy 18, and trisomy 13. And in Down syndrome, I'm going just to bring for you our recent experience for the differences in mortality and morbidity in Down syndrome that are related to the type of the congenital heart defects. Our experience on more than 500 patients that we have seen that the most common is the atrioventricular septal defects, and these are the typical, we have called them the typical congenital heart defects. And they were not different from that reported in literature. But then we needed just to analyze what is often gets in a second stage, and let's say that's considered less important in Down syndrome, which is the atypical congenital heart defects. And mainly we have analyzed those patients with univentricular physiology in terms of survival. And we have identified that patients, the mortality of patients with Down syndrome and with typical congenital heart defects, they are mainly non-cardiac deaths. They are caused by cerebral hemorrhage or infections. While patients with atypical congenital heart defects, those with univentricular physiology, Down syndrome with univentricular physiology is the main cause of death, and it is cardiac deaths. Moreover, we have identified that patients with congenital heart defects that are typical for Down syndrome, they have much better survival, while those with atypical ones, they have had less chance for survival, reaching 84% at a distance of 40 years. So we analyzed the literature for this, the univentricular palliation in Down syndrome, it's very controversial subject in literature, and many reports in literature are against doing it, mainly because patients with Down syndrome, they can have more complications due to hypotonia, big tongue, and also to elevated pulmonary vascular resistance. The only report in literature that says there are no significant differences between Down and non-Down syndrome in facing the fontan is only one report. While all other reports say if you need just to manage a univentricular physiology in Down syndrome, maybe you have just to try for biventricular correction or biventricular conversion. Another aspect which is very important maybe for the surgeons to know, that the risk factors for patients with trisomy 21 is the low cardiac output syndrome and the multiple ventricular septal defect and the high vasectomy entropic score. These are the major risk factors for delay also in extubation and in favorable outcome. If we go and see other chromosomopathies, there are many and many that can be associated with congenital heart defects. One of the frequent scenarios that we see is the females with left-sided lesions with Turner syndrome. Since patients with Turner syndrome, they have congenital heart defects in 23%, and then maybe left-sided lesions with bicuspid aortic valve coarctation or hypoplastic left heart syndrome. One of the progressive nature of the Turner syndrome, not to forget for clinicians, is the late hypertension. When we go deeper in the cryptic, let's say, chromosomal abnormalities, we found the classic microdeletion of 22q11, the bilocardiofacial or DiGeorge syndrome. I'm just going to tell you our friend Jada, that I have seen her in my first years in Bambino Gesù when I was a doctor of the pediatric cardiology ward. And it is, and Jada, she was born in 2007, and she is affected by pulmonary atresia, ventricular septal defect, and collaterals, MAPCAS. And the surgeon gave the note of absent thymus, and the post-operative complications were pneumonia, hypocalcemia, feeding difficulties. I believe this scenario gets repeated with patients with microdeletion of 22q11. But it's important also to remember that the phenotype changes in these patients. And when we see young infants or children, the phenotype in the adult is really changing. And this condition is relatively frequent in the general population. If we consider it, it's 1 over 4,000. And the congenital heart defect is reported in 74%. And it has a multi-organ involvement in a very variable percentage. And we try to do our best always when we get the new diagnosis of patient to get the referral to practical guidelines for managing these patients. Since we know that these patients, they can have immunologic complications, they need specific also pre-operative preparations. And other interesting information for the surgeon, that we know these patients, they are predisposed to have aspiration pneumonia or repeated intubation. It can lead also to problems in the airways, since they are already having problems in the upper airways. Another emerging aspect that can be of help for those who are dealing with Gooch is the psychiatric complication in patients with microdeletion 22. When we go and see the percentage of the congenital heart defects, as we have said, it is something like 75%, and the most frequent one is the tetralogy fellow. But on the other hand, if we are called to an intensive care unit and the diagnosis is the interruption of the aortic arch, one of the first diagnoses that we must exclude is the frequency of 22q11 deletions, since it can reach to 80%. The emerging aspect that's getting also reported in literature is the progressive nature of certain defects, such as the aortic root dilatation in patients with microdeletion 22. A report in 2017 gives the information that the hospital mortality in patients with other genetic syndromes is in other genetic syndromes versus non-genetic syndromes, it is higher. But if we can see it compared to 22q11, it is almost similar to those with patients with non-genetic syndromes. And the same thing, if we can notice that patients with genetic symptoms other than the 22q1 deletion, they need the ECMO or unplanned reoperation. On the other hand, the length for the stay, for the post-operative stay and staying in intensive care unit for patients with microdeletion 22q is higher than those for patients that they don't have any syndromic condition. Hopefully, the survival, it is almost similar to those for patients with no background genetic condition or genetic syndrome. Another condition that I would like to share with you is also a microdeletion syndrome, another microdeletion syndrome that is often characterized by feeding difficulties, failure to thrive, reflux, prolonged colic, and other problems in the first year of life include chronic otitis media, rectal prolapse, or hernias. In this patient, we see pulmonary artery stenosis, hypotonia, and hyperextensible joints, and it is the Williams syndrome. The Williams syndrome, this is a rare condition, 1 over 20,000, 50,000, and it's caused by microdeletion of the long arm of chromosome 7, including the elastin gene. And also these patients, they need multidisciplinary evaluation, and it must be periodic with time, since their problems change with time. Here as well, the congenital heart defects are found in 75% of patients, and previously part of our group have described that the most frequent one is the supravalvular aortic stenosis and then the pulmonary stenosis. However, more rare forms are also reported. The supravalvular aortic stenosis, it has really a very specific shape and specific characteristics, and it is reported in patients with Williams syndrome. From our experience, if one patient has a negative FISH exam for the microdeletion of Williams syndrome and has this specific phenotype, we test also for the elastin gene, and we have identified a few families that they are positive for this condition. The natural history for this condition in Williams syndrome depends on the severity of the lesion at presentation. Another condition is the pulmonary artery stenosis in Williams syndrome, and it's common to see in the first year of life, and it usually improves in the first few months of life. Other stenosis, they can include coronary artery abnormalities or of the thoracic aorta, but we must know that the elastin is the gene that is very predominant in the arteries, so any artery can be affected in the body of the patients with Williams syndrome. That's why we highly recommend that when there's a new diagnosis of patients with Williams syndrome, and especially if they must face a surgical operation, is to do the imaging of the head and neck vessels, in order to exclude any involvement of these vessels. Another progressive nature is the predisposition to hypertension, of course. So, chromosomal anomalies in syndromic congenital heart defects, we see often Down syndrome, Turner, microdeletion, but this is only the point of an iceberg. But in our daily activities, we often face also some rarer forms where we don't have guidelines and we have to study each case in an individualized matter, since any region of the chromosome can be involved, leading to chromosomal congenital heart defects. Then I'm going just to bring an example from the monogenic diseases that are the most frequent ones with the congenital heart defects, which is the Noonan syndrome and clinically related rasopathies. This is a relatively frequent condition in the general population, and sometimes we identify a parent, a mother or a father, that has the full phenotype, I mean phenotypic phenotype, without a congenital heart disease, and we make the diagnosis after the diagnosis of a child with a congenital heart disease. And there are many genes that can cause the Noonan syndrome, and it has characteristic features. However, the face of these patients can be very variable. Shorter stature in certain forms of Noonan syndrome, not in all of them. One of the interesting conditions for the surgeons is the coagulation defect that can arrive up to 33%. So this is one of the screening that we do preoperatively for patients with Noonan syndrome. The differential diagnosis for Noonan syndrome is the Leopard, CFC, mutations by SHOC2 or Costello. The congenital heart defect in this condition is more than 50%. However, an ECG abnormality can be even documented up in 90% if it is seen by a person who can read well the ECG in these children. The genotype-phenotype correlation in Noonan syndrome is not so easy, especially for the very recent forms that are described in the last few years. But in a general manner, we know that in Noonan syndrome, we see more pulmonary stenosis than septal defects, while in Costello, we see more cardiomyopathy compared to pulmonary stenosis. However, we know that there is a very high variability, and actually in our group, we have described several patients with atrioventricular canal in rhizopathies. And as well, sometimes we call one of these genes of the Noonan that is characteristic of the congenital heart defects, but it's not always like that, because sometimes the same gene can cause also cardiomyopathies. Another difficult aspect for a clinician is the clinical diagnosis for children with rhizopathies in the first year of life. Actually, in most of these cases, the heart is the part of the clinical data that can help us to make the diagnosis in this group of patients. I just would like to share with you this study that has been performed by part of our group, where we have where it has been described that the cardiac defects has been found in 80% of the cases in Noonan syndrome. And the cumulative survival, it was really good. It was 94% in 20 years. And the risk for intervention was higher in individuals with Noonan syndrome and pulmonary stenosis, especially those positive for PTPN11 mutations. Another aspect is that we analyzed in that study the mortality, and the mortality was relatively low, but specific association was related to hypertrophic cardiomyopathy, biventricular articular tract obstructions, and PTPN11 mutations. Now I'm just going to tell you about one condition that was discussed in a more detailed way in the last webinar about the heterotaxy. The majority of patients with heterotaxy, they have unknown genetic background. However, there are several genes that are now emerging, especially with the NGS technique that I'm not going to discuss here. But my main interest is the importance of multidisciplinary management of patients with heterotaxy. We know that we think that we are perfect, but it is not like that, because the laterality and the imperfection or the asymmetry is part of our perfection, let's say. So in patients with right atrial isomerism, we have two right atrium. And in that case, we can imagine we don't have left atrium. And so in that case, the pulmonary arteries, they get lost in a simple ways. And one of the most frequent malformations that we see is the anomalous pulmonary venous return. While in left atrial isomerism, we see two left atrium. And in that case, we can imagine that we have a defect in the main battery of the heart or in the conduction system. And actually, in a study that we have performed analyzing the long-term survival and the phenotype in heterotaxy, we have identified that from the multivariate analysis that left atrial isomerism is an independent predictor for pacemaker implantation. Another aspect that we have analyzed in these patients, because it's often misleading to call right atrioisomerism as asplenia or left atrioisomerism as polysplenia. And actually, in our cohort, we have identified, and the same also from different literature revision, that the asplenia is present in the right atrioisomerism in half of the patients, while polysplenia it was in 32%. And left atrioisomerism, there was polysplenia in 64%. And there was a normal spleen in 16%. So it's really variable, and each patient needs to be evaluated individually. Regarding the long-term survival and freedom from heart transplant, it reached 70% for the right atrioisomerism and 87% for the left atrioisomerism. And here we plotted the Kaplan-Meier curves for the previous known studies, and we compared it to our cohort, and we have identified a significantly lower mortality compared to all the studies. This is probably because of experienced techniques in surgical competence, or even the improvement in ICU management, as well as the very important part is the immunological surveillance in these patients. And actually, we have reported that in one study that early treatment and a prophylactic antibiotic and specific immunization program, it can reduce the mortality in asplenic patients with heterotaxy. Here, I would like just to bring you very few examples, because sometimes we think that the congenital heart defects is just a world that is detached from the rest of the inherited cardiac diseases, but it is not like that always, because sometimes there are mixed phenotypes with congenital heart defects. For example, I'm just going to bring you the example of patients with cardiomyopathies having congenital heart defects, because we know that cardiomyopathies in children is a rare disease, and since it is a rare disease, so it needs a particular attention. And we know that different cardiomyopathies can be caused by different genes. So the impact of genetics in clinics in cardiomyopathies and with the overlap of congenital heart disease, I'm just going to bring you the example of a patient that she was diagnosed at birth with atrial septal defect, left ventricular non-compaction. At the beginning, it was without any dysfunction and multivalvular dysplasia with mild dysmorphic feature, and she's from the Gypsy Roma origin ancestor. We did many investigations, including the metabolic investigation, and they were negative. And with time, she developed ventricular dysfunction and dilated cardiomyopathy, reaching to an ejection fraction of 30%. The ECG showed both Parkinson-White. And when we did genetic investigations, we identified TMAM70 mutation. So what's the impact on these diagnoses for these patients? Because we know that when we diagnose patients with metabolic diseases, we have just to check if this is eligible for heart transplant or not. And we know in that case, there is the importance of a specific ICU precautions and prevention of complications. And sometimes we see that the patient is ill, but we don't understand why they are ill, and because there is a metabolic decompensation that if you don't go and look for, you can't help your patients. Another example is of the interaction of the cardiomyopathies with congenital heart defects is the predictive value according to specific genetic conditions. So it's a genotype, phenotype, and management correlation. So our patient, we have seen him something like 5 years ago. He was born with the aortic coarctation, bicuspid aortic valve, mitral cleft. He had the surgical intervention. He had some orthopedic issues and epilepsy. And then we checked for the family history. The grandfather had pacemaker and heart transplant. The mother of the grandfather had a sudden death at 40 years old. And when we checked at that time, 5 years ago, we used to do the panels, but now we do the clinical exomes directly. When we checked for the panels, we identified laminae mutation. And when we sent the mother to an adult center, she had a 40% ejection fraction, and she received an ICD after that evaluation. And so they said, well, this is a coincidence. The aortic correctation with the laminae has nothing to do. But then we checked our cohort, and we have analyzed 6 patients, and we have identified that we have another patient with aortic correctation, and we have 1 patient with repaired VSD, and 1 patient with the dilatation of the aortic root. So there might be some mixing. There might be other factors, other genetic factors that we are unable to identify. But however, sometimes it's important to have some kind of, we call it brain elasticity. Also because making a diagnosis of laminae changes the management of these patients, since we know that there are certain European Society of the European Society of Cardiology guidelines that the management of patients with laminae is a bit different than those without a genetic background. I'm going just to bring you the example of one condition, a liquitrical condition, let's call it, with mixed phenotypes with congenital heart defects. It is regarding the TBX5 mutations. Because previously, this gene was reported to be causative for Holt-Oram syndrome, giving the main phenotype of upper limb defects. Congenital heart defects, mainly septal defects, and less frequently complex heart defects, and conduction defects, bradyarrhythmias. However, recently there are multiple evidences that they are reflecting a potential role of this gene on dilated cardiomyopathies and tachyarrhythmias, and not only on bradyarrhythmias. Actually, there's a very interesting recent study. So when we see patients with a genetic condition that is caused by specific genes, we just have to take also in consideration the progressive nature of these diseases. So it's not a static condition, but it's rather a dynamic one. So in conclusion, the congenital heart defects, they are highly heterogeneous. And the cardiogenetic evaluation, it can help in establishing diagnosis, but as well in focusing on multi-organ work for these patients and multidisciplinary management. And congenital heart defects can be caused by almost any genomic regions. And some conditions can be reported really in a very rare way. And it's very important that we must not forget that rare CHD phenocopies, they do exist even in daily practice in our tertiary care centers. This is our main branches that we see in our cardiogenetic clinic: the congenital heart defects, the major part, cardiomyopathies, arrhythmias, and aortopathies. I'm sorry I didn't have time to talk about you. We have very interesting examples of aortopathies, but I'm afraid that I'm running out of time. So around the child with congenital heart defects, we need the pediatric cardiologist, we need the cardiac surgeons, but we need also a lot of people around. So it's a matter of teamwork. Thank you.
Thanks, Anwar, for the interesting and very clear presentation. Grace, can you send the poll?
This is not mine. This is of Jed.
Yes.
Sorry.
No worries.
May I tell something?
Yeah.
Okay. Regards to your nice lecture, thank you very much. I would like to say, regards to my experience, because most of time in the one of the pedigree, we find many different penetrance of one phenotype in family. It's very important because the doctor or surgeon or pediatrician should be keep in mind, maybe in some case they find ASD, but the other case in other generation with same mutation and find we we should be keep in mind the different penetrance with different phenotype. Maybe
Exactly.
find in the one family one mutation. On the other hand, for the sporadic cases, most of the family ask the genetic counselor or pediatrician, what about the next children? What happened about that? We should know about the sporadic case, the recurrent risk. It's happened. It's 2 to 4% for every child, and if the mother has this problem, maybe the risk go up 1 to 10%. I have a question because it's my challenge in my country. Most of time in the fetal echocardiography or in the neonatal, we find some congenital heart disorder. Most of time we don't think about, and we didn't find any syndromic. So how we approach this by the geneticist? I try to do the request for the CGH array because I think most of these type of problem depend to deletion or duplication. What's your suggestion about this issue?
Well, if I understood correctly, sorry, you were telling about the variability within one family. That in one family you can see it's just like that. We tell the patient sometimes that one gene is like the principal part of the tree, but this is a magic tree since it can give apples and pears, or it can give apricots. So it's the same gene. It can give variable expression. It can give different types of congenital heart defects. If I understood right, the first comment. The second thing that you were, if I understood correctly, you were telling that most of these conditions, well, actually, for the array CGH, we do them, and it can be of major help when you have complex patients. I mean, when you have patients with multi-organ involvement, when you have the syndromic patients, it can give you more satisfaction. While those conditions with the isolated, sporadic congenital heart defects, I don't know how much it can be of help. I believe, well, Elle and Becca can correct, can give me also some help, but I believe that the percentage is less than 5% if it is an isolated and sporadic congenital heart defect, and you do the array CGH.
Thank you.
However, it can be of help. I think that the personalized medicine is the right word for these patients.
Thank you, Anwar. Thank you very much. Now it's time to start with the poll. Sorry.
Okay.
This is your poll.
No.
Just showing the results of the first question. So
no, it's not mine.
No,
I know. I'm going to give yours now.
Yes.
I think that's your first one?
Yes.
Oh, good. We won't have time, I think, for all of them, but we can stick to one question. And then in the end, if we have time, we can do more.
Okay, so I should read them? Sorry?
Yes.
Yeah, okay. Well, in patients with microdeletion of 22q11 syndrome, it's always associated with congenital heart defects. What do you think?
Make some suggestions.
Okay, I'll make some suggestions. Okay. Well, should I go backwards with the slide? Can I make it?
No.
No? Okay. Okay. Well, In this condition, most of the cases they can have congenital heart defects, but
Here
it's
the
not.
results, but Anwar, here the results. Have a look.
Okay.
Are you happy?
It's 75% of patients, they have congenital heart defects, not all of them. Okay.
We go with the next one.
One more?
Yes?
I will launch.
Well, a teenager with a history of increased nuchal translucency in prenatal scan. She has bypassed aortic valve. She has amenorrhea. And she's in follow-up with the endocrinologist. What's the most probable diagnosis? So she has shortest stature, amenorrhea, and she has a left-sided lesion. She has a bypassed aortic valve. I don't think it's allergy because she doesn't have liver problems, so it's not allergy.
Here we go.
Yes, wonderful. That's cool. That's very nice. Thank you.
May I tell about the Turner syndrome?
Wait. No, wait. At the end of the main session. Now we have to.
Okay.
Thank you, Siam.
Okay.
Now we have another one.
Well, in heterotaxy, right atrial isomerism is always associated with asplenia. So do you think that it is right that we call every neonate with right atrial isomerism that he has asplenia and we don't go and check for the spleen? Is it right? But we know that there's a very high variability. It's a bizarre, let's say, laterality defect.
Okay, here are the results.
Okay.
Are you happy?
Okay.
Okay, thank you, Anwar. Can you stop sharing your screen, please?
Yes, sure. Stop sharing. Thank you.
Now Dr. Getz will begin a new presentation. Gabriel is pediatric medical genetist, medical director of cardiovascular genetic Relay Hospital for Children, associate program director, associate professor of genetics and pediatrics, Indiana University.
Okay, can you hear me okay?
Very well.
Okay, great. So I'm going to talk to you a little bit about our cardiogenetics experience in the Midwest. I have no conflicts of interest or disclosures. And so we're going to start by talking about some myths and truths about cardiovascular genetics, trying to keep with the title of the session. Then we're going to go over some ways that you can talk about common genetic tests that are run in this population with families. And then we're going to spend a lot of the time talking about sort of our Midwestern cardiogenetics program experience. And so just as Anwar said, cardiogenetics, which is a very small section of medical genetics, is an overlapping set of these things, but within it, the genetics of congenital heart disease is the most difficult and diverse of the topics. And so it's something that we definitely could spend many hours, maybe days, talking about. And so we're going to sort of focus on the congenital heart disease and the practical aspects of it. And so going into some of those myths and truths, statement one is cardiovascular geneticists do research, they don't see patients. And honestly, this is both a myth and a truth. Geneticists who do and specialize in cardiovascular genetics are certainly much more likely to be focused on research than the average physician. However, there are ones like myself who focus primarily on clinical care. The next statement is genetics is impractical for patient care in infants with congenital heart disease. Just as Anwar showed, I hope that this is easily seen as both a myth and a truth, because there are very practical applications for genetics to the care of patients with congenital heart disease. That being said, geneticists sometimes get in their own bubbles, and we can be sort of the epitome of an absent brought back down to earth of this is what's going on with the patient and this is what we need to focus on right now. I would be lying if in team meetings before I hadn't admitted that I'd been talking about something and one of the cardiologists sort of was like, the kid's on ECMO. Like we need to sort of focus and get back centered to what is most critical to be applied to this patient in this moment. And then the final statement is I consult, think about genetics on infants with critical congenital heart disease when it's appropriate. If you believe you're doing this and it's not every patient, that absolutely is a myth. And hopefully by the end of this webinar, you'll feel that way too. So just spending a little bit of time going over how we talk about common genetic tests with families. The analogy that I use is that your genome is a library. And within that, you have the bookcases, which are like chromosomes. And this is where you can sort of bring in the karyotype analysis of it sort of generally looks over the number of bookcases and the general position of the bookcases. So karyotypes or chromosomal analysis just gives you a big idea of the genomic structure. And it's just growing cells under a microscope. And that's important to know because you need to work with living cells in order to get those metaphase cells. So that sometimes is an issue when you're talking about where you're getting your sample. Karyotypes can uniquely assess for low-level mosaic chromosomal conditions and balanced translocations. And then going into your genes, they're like books. And so typically when I talk about that, I talk about the chromosomal microarray, which looks at copy number variation on extracted DNA. So this is looking for the missing or extra books and can detect things like 22q deletion and that sort of thing. So it doesn't see structural differences because you're just looking at ratios of DNA. So that's why in conditions like trisomy 21, we still need to complete that karyotype or chromosomal analysis to ensure we're not dealing with a balanced translocation. And microarray is considered sort of standard first tier evaluation for infants with critical congenital heart disease and really congenital anomalies, autism, developmental delay. The list goes on. This is one of our first go-to tests. And then going into the books, variants are typos. And so if you look at a sentence like this, look at all the bright colors, there's actually a lot of different ways that you could write that and variants of that. And a lot of them actually still make sense, even though they're wrong. And that is true for our DNA as well. We have lots of variants in our DNA across our over 20,000 genes. We have millions of variants, and 99.9% of them are benign. And our body reads right through them and knows what they mean. But as we test more genes and do more expanded genetic testing on a day-to-day basis, we need to be aware that the testing comes back with more variants and variants of uncertain significance. And this is one of the many reasons that we're trying to phase out the word mutation from our vocabulary, because mutation is sort of associated with a bad thought in that the variant is disease causing, when in reality the majority of our variants and many of the variants reported back on genetic testing may not be disease causing. So that brings us to exome sequencing, which we have which we use as sort of our first tier on the infants where I am. And so exome sequencing looks at the coding portion of DNA extracted from our DNA, but the exome, the coding region, is actually only 1% of our whole genome. And capturing this DNA, actually, it doesn't catch all the genes. There's typically at least 1,000 or 2 genes that aren't fully covered. So it's possible that there are holes in this diagnostically. So that's when geneticists talk about coverage or going back to check the coverage of that gene. That's why we're sort of doing that. And that's why we're trying to get away from whole exome sequencing, because it's never really whole. There are always going to be gaps. The part that makes this okay, I guess, is that of those 20,000 genes, we've only associated disease with less than a third of them. So even when we're doing this exome, we're looking at less than a third of 1% of our DNA, which when you put that into perspective is crazy that we ever find any answers in looking at that little part of us. We also now, through bioinformatics, can see copy number variants on exome sequencing. So when we say that looking for copy number variation is our standard first tier, we can now say that we can do this through exome and perhaps be moving away from array as our first tier. The trick is that this only covers genes. It doesn't cover introns. So once again, you can have a diagnostic hole there. A couple other comments on exomes, and I feel the first time you see an exome, you are very much like this lady at the computer, just shocked by what it looks like because there are so many variants. One thing I do with my students is I show them my exome and see how many diseases it looks like I have on ClinVar and things like that. It's just a mess. So if you ever have the opportunity to look at raw data, I suggest you do because it gives you a greater appreciation for just how frequently there are variants, and you become much more comfortable with variants of uncertain significance. But there will be variants of uncertain significance, and if you're going to work with exomes, you absolutely need a geneticist for variant interpretation backup and for patient phenotyping. In addition, exomes open up the possibility of secondary findings, which can be for adult onset conditions like BRCA1 and 2. You're talking to a sleep-deprived new parent in the ICU who's overwhelmed and maybe can't even hold their baby, and you're going to talk to them about adult onset cancer predispositions. This is one of those things where geneticists can get a little too esoteric and miss what's in front of them. And so what we tend to do to avoid those conversations and to avoid adding extra stress is we do exome-based panels. So we, perhaps a bit paternalistically, make some of those decisions of right now we're focused on causes for the heart defect and things that will affect them in the perioperative period, bleeding disorders, malignant hyperthermia, pediatric onset disorders, and sort of shield the parents from trying to figure out and assess and deal with that excess information. And so that's just sort of a brief overview of how to talk to parents. Now going into the Midwestern Cardiogenetics program experience. So what is the Midwest? The Midwestern United States is just sort of the hole in the middle. And I realize that a lot of you might not be particularly familiar with it. And yes, this is not an accurate map. But the places that I've been, I started in, I was fortunate to be introduced on how to operate on infants with critical congenital heart disease by watching a tetralogy of below repair with Dr. Michelle O'Bowie, where he let me sit like right over his shoulder, basically touching him while he was operating. And that was in Chicago between 2010 and 2013. Then I was in Milwaukee, Wisconsin until this fall. And then this fall I transitioned to Riley, which is in Indianapolis, Indiana. So I can't represent the whole Midwest, but at least we have a bit of a tour around of 3 different very high functioning centers. All of them have had 3-star STS ratings and all, have been like top 10 US News and World Report centers. So I've been very fortunate to work with great teams. And so some of the things I learned at these locations, in Chicago, I think the first thing I learned is that no one's as organized as they think they are when it comes to genetics unless they have the data to prove it. So when I moved to Milwaukee, I was definitely told that, oh yes, we do arrays on everybody. We get genetic consults on everything when it's appropriate. And when you see the data that I'm going to show, you'll see that simply isn't the case. So unless you have the data to prove it, I'm not going to believe that you're doing what you think you're doing. And then the other is protocols, because that is really how you it so that it's automatic and not open for interpretation or error. And then in Milwaukee, I really learned that you really have to be part of the team to get appropriate perspective and know when patients change. I've made a lot of diagnoses just by sitting in meetings and hearing an update about a patient during sign out and saying, hey, I need to go back and look at that patient. And going back and looking at them, I realized something I didn't realize before. Or with that extra piece of information, I realized something I didn't connect before. And so being integrated is really important whenever possible. And it also made me realize that we don't crosstalk across academic lines enough. So I've never been to a formal cardiology meeting other than the ones hosted at my own institution in Milwaukee. And I was sitting in the audience watching speakers who I often spent hours and hours with every day. And I had no idea on the work they were doing. So let alone that insight for individuals across the country. And once again, I'm going to give one example in the next few slides that hopefully will help take that point home of we need to be discussing more than we are. So now let's go to a way that we've changed care. We already have done this. And this is for just looking at diagnosis rate across 3 approaches to genetic testing and assessment in infants undergoing surgery at less than a year of age. And this is excluding trisomy 21 because that one's too easy to diagnose. So we just took it out of all of these different populations. So this data is from Milwaukee. And so our baseline testing when we were, quote, doing arrays on everybody was 15%. So 81 out of 525 individuals. And our results, our rate of array, I think was less than half. So we certainly weren't doing arrays on all of these individuals. So then we instituted a genetic testing protocol to say, okay, now we're going to try to do arrays on all of these individuals to make sure that we catch them. And when we did that alone, we raised the diagnosis rate to 23%. That was just the protocol alone. You'll see that this is only on 115 patients. This is because it was sort of a short time period between when we were just on the protocol and then when the cardiogenetics program started. And so then having sort of protocolized genetic testing and protocolized assessment by a cardiovascular geneticist, our diagnosis rate went up to 32%. So we diagnosed 87 individuals out of 274. We got more diagnoses in about half the sample size than we did in our 525 patients. And so we made a huge difference just by standardizing and having medical geneticist assessment. That being said, as we'll also talk about, there's a limitation to having access to geneticists. And that's an unfortunate reality. So we have to come up with some novel solutions for this to make sure our kids are getting the best care. And then just to sort of put a disclaimer on this data, obviously all of these times we're moving forward, and with every year there are significant differences in how we look at genetics, access to genetic testing, all of those things. So it's possible that the diagnosis rate was also naturally going up in conjunction with these changes. An additional benefit of the cardiogenetics program is an increased number of dual and incidental diagnoses that were only found because of geneticist assessment. So baseline, looking at those 525 infants in the first cohort, there were 2 dual diagnoses and 1 incidental diagnosis. And so one of the dual diagnoses was 2 chromosomal anomalies, both detected on array, and one was 22q deletion with Cornelia de Lange syndrome. So a complex dual diagnosis that wasn't actually found until age 4, when the child underwent exome because they had not followed the expected course. And our one incidental diagnosis was a diagnosis of hemophilia, which obviously is not a great combination with congenital heart disease, but was basically screamed at us by the family because they had this family history. So they told us before the baby was even born that there was this diagnosis. After the cardiogenetics program, so once again, looking at those 274 infants, we found 13 dual diagnoses and 13 incidental diagnoses that altered care. And this was all sort of in the first few months of life, if not the first year of life. So knowing that information is so critically important. And one example I give, partially because it's a little embarrassing and I get to make fun of myself, but partially because it's also important, is a patient we had with heterotaxy who also had oculocutaneous albinism. And the reason it's embarrassing is I did not make that diagnosis clinically. I distinctly remember walking in the room and thinking the patient was extremely pale and needed a blood transfusion. She was of Scandinavian descent, so in my defense, she should have been pale, even independent of her albinism. But then when that came back, it was very critical of like, yes, what if this child develops nystagmus? Everybody's going to freak out. She's been on bypass, that sort of thing. And we were able to say, hey, like, let's get an eye exam. If she starts exhibiting signs of nystagmus, as we sort of, take her off sedation, those sorts of things, this is what's going on. It's not any new neurologic symptom or anything like that. And provide that level of reassurance that hopefully saved some interventions and some heartache and worry. So early, comprehensive diagnostic evaluations and genetics assessment just makes such a big difference and can really help us understand the risks of these genetic conditions so we can mitigate them. And that's where, once again, we get into the genetics is practical and also not practical, because so much of this, we don't fully understand the risks. We just know there are risks. And it's only at the highest level centers where they have impeccable outcomes that the genetic effects are really going to stick out of what they're sort of how they're affecting outcome. And we can't really tease that apart unless every patient is assessed systematically. So we have that information comparably on all of our patients and then can look at it. And so we need this information not only for patient care, but looking into the future of how to make genetics more practical. And so then I want to talk about a project we did last summer that is unpublished and has been a bit of a casualty of my moving, which is why it's not published, but of how we could change care and hopefully really emphasize why we need to, once again, sort of cross those academic lines better. And so this was a project we did looking at 35 infants who underwent Norwood palliation during the duration of the cardiogenetics program. So all of them had had a physical exam in the first few days of life. And we had pictures, because I take pictures of all my patients, and we're able to go back and sort of independently confirm this infant was syndromic based on facial features, this one was not. So of those 35, by facial features, 13 were syndromic and 22 were non-syndromic. And we considered heterotaxy syndromic by default, even though frequently their facial features may be relatively reassuring. And so we looked at what were the differences in some of the outcomes across these patients. And obviously, it's an incredibly small sample size. And this is sort of a a big table, not as big as all the data we have, but let's sort of go through what we found through some of the more important points, I think. And so the syndromic infants were 5 times more likely to have a genetic diagnosis, which to me just, I think, means I was doing my job correctly of identifying these features. Syndromic infants were ventilated postoperatively for double the time in hours on average compared to the non-syndromic infants. Length of stay on average was a month longer than the non-syndromic infants. And the mortality as defined by the STS database was 6 times higher in the syndromic infants. Now, obviously, this is really limited by such a small sample size. But we don't have a lot of data on facial features in this population as related to outcomes. So at the very least, I think this data shows we need to take a pause and think about what could we do with this information. And then once again, these are just sort of the exact numbers. And you'll see that mean length of postoperative ventilation and number with genetic diagnoses were both statistically significant despite the really small sample size. And mortality was actually 0.052, which I was not expecting anything to be remotely significant in this sample size. So I was surprised that our numbers came through with anything being significant. And so that brings us back to how could we change care? And so you might say, like, that's great that you can look at facial features, but you're in that Midwest and you're not at my center, so that can't help me. Well, actually, maybe it can. So working together, we could design novel risk stratifications, for example, using facial recognition software, making it accessible to any child with critical congenital heart disease whose surgeon has a smartphone. Some place where this does get a little more problematic specifically for our population is when they're intubated, which a lot of our patients are, and then postoperatively when they're really edematous, because that does make it harder to appreciate those facial features. And that's where some of the human training would need to come in into sort of helping stratify these patients. So we could design this by either saying, hey, let's look at the SVR trial, and all of these parents have pictures of their kids, good frontal facial pictures. What if we decided to go back and try to get some of those and then put them into the AI, like facial recognition software, and tried to correlate that just by outcomes? Or what if you got a group of people like me and Becky and Anwar, and we reviewed pictures and classified them as syndromic or not syndromic? Prospectively, retrospectively, we could be completely blind to the outcomes and just look through those facial features. And whatever patterns we're seeing, we could train the computer to see. And so this is something that I'm guessing a lot of the cardiologists and surgeons and team members who are working probably had no idea that we're working on facial recognition software in genetics to look for genetic syndromes. So this is one of those things where I think, once again, cross-talking across, what did you learn at your meeting? What did you bring home from this is really, really important, and something that I think we need to do better on, which is one of the reasons I've really, really enjoyed these webinars, is because I don't get to go to cardiology conferences, but I got to see our heterotaxy conference, our hypoplastic left heart conference, and it gives me much more insight as to how I can better apply genetics and how we can come up with extra ideas to try to extend our reach. And so going into some of the take-home points I really want you to take away, all infants with critical congenital heart disease should have an assessment by a medical geneticist. Unfortunately, this is impossible. Medical geneticists, at least in the US, are in short supply. Since our last board exam, there have been a total of 1,762 medical geneticists ever certified in the US. This includes those who are dead and retired. The average age of the practicing medical geneticist in the US right now is over age 50. So this is only going to become a more scarce resource. And looking at our training slot positions in the US, less than 30% of our slots filled last year. And this is because people aren't applying to become medical geneticists. And yeah, we could talk about that. I know you guys aren't interested in that, but we need to come up with ways to extend our reach as not only just medical geneticists, but as cardiovascular geneticists. Because as geneticists, once again, we're covering that whole huge circle. So we're being pulled to patients with inborn errors of metabolism. We're being pulled to these rare diseases that nobody else can care for other than us. Even though congenital heart disease is the most common birth defect, there are other people to care for them, and they sort of end up being neglected by us, unfortunately, because we're pulled in so many different directions. So once again, sort of that crosstalk of what's happening between specialties so we can better understand each other and come up with solutions. And then all infants with critical congenital heart disease at least should undergo molecular assessment with a chromosomal microarray looking for copy number variants. So at least we should have that going. There are testing protocols that you can put in place to standardize this and ensure that this happens. And I know that I personally have helped at least 3 or 4 centers institute this at their place. So people are willing to help you put this in place and troubleshoot what problems there are. One of them being me. So if you want to email me about this, I'm happy to help you wherever you are. And then last, once again, we need to figure out a way to work together to get the best genetic care and assessment for these infants, because we have limited resources, a lot of patients, and a lot of potential to really, really make a difference. So on that note, I just wanted to give the shout out to the teams that I've worked with to get this data and to learn these lessons, because it's so critical to work with them. And so the CVICU, the NICU, the cardiothoracic surgery and cardiology, and countless others who are part of our nursing, our heart center teams are really critical to making all of this work. And once again, that communication and teamwork is just so critical. And then I'm not sure if we have a few minutes for questions right now. If not, you can put them in the chat box and I'll respond to your chat message, or we can ask them at the end. Well, thank you very much.
Thanks, Gabriel. Great presentation. We'll see the poll at the end of the last session, okay? Now let's listen to Dr. Arendt's Niklas presentation. Dr. Niklas is Assistant Professor of Pediatric Division of Human Genetics and Metabolism, Children's Hospital, Philadelphia.
Okay, thank you so much for letting me participate in this really interesting session today. And I'm really going to be building on the 2 previous talks that you heard that provided such a nice discussion and introduction about genetic testing and genetic evaluation in patients with critical congenital heart disease. And the population I'm really going to focus on as an example population today are infants under a year of age with critical congenital heart disease. And I'll be talking through the utility of a genetics evaluation, both a clinical genetics evaluation, like Al was talking about, and also a lot of the genetic testing that we send. So, I have no disclosures to report. I don't need to introduce congenital heart disease to this population, obviously, but it's important to remember that it's the most common birth defect, affecting about 6 to 9 out of 1,000 live births, and is associated with a very significant morbidity and mortality. If you look at
all congenital anomalies in terms of standardized death rate, you can see that congenital heart anomalies, shown here in red, are associated with an age standardized death rate of about 4.5 per 100,000 deaths. And so you have to compare that to all the other congenital anomalies that we see, and this really does have a high rate of mortality. But it's important to remember that the mortality from congenital heart anomalies may also be associated with some of those syndromic diagnoses that we spoke about and all the other burden of disease that infants with syndromic congenital heart disease suffer from. And so this paper is a wonderful one that was referenced already in an earlier talk, but thinking about this idea of myth versus reality has been a discussion and an interesting discussion that's been going on for more than 50 years. This paper was originally written in 1968, and it's this beautiful discussion about the genetic environmental interaction that leads to manifestation of congenital heart disease. And they have a figure that I still keep on my desk because I think it's a really interesting one to think about how this relationship between genetic factors and the environment lead to congenital heart disease. And this idea that you could have a multifactorial approach where you end up having many risk alleles within an individual, many genes that might have small changes that when interacting with the environment lead to a congenital heart defect. And then you can have different cases where you have a clear chromosomal anomaly or a single gene mutation interacting with the environment leading to congenital heart defects. And even though this was developed this picture was written in 1968, we still think about genetics of congenital heart disease very much in this manner. And so we start thinking on many different levels of where a genetic defect or a genetic variant might predispose or lead to congenital heart disease. And so this is really just a reminder, based on all the discussions that we've had already, about the different types of genetic testing that's available. Really going from sort of the big picture of a standard karyotype, which was described beautifully, and really you can look at a karyotype to look for extra chromosomes or translocations of chromosomes or large deletions or duplications of chromosomes. You're then able to zoom in a little bit more finely using a microarray, which we've referred to a lot already today, which is really able to detect small deletions or duplications. So we always tell families small pieces of DNA missing or extra. And then if you zoom in even further, you start to look at a base pair level. And you can do this with a variety of testing, whether it's targeted gene testing using a next generation sequencing approach or other sequencing approaches, or the newer technologies that we spoke about a lot today, exome sequencing and looking at all the coding regions. And again, it's spell checking those genes, or genomic sequencing, which is looking at both the coding regions, the exons and the introns. So we've had a beautiful introduction to this already, but just keep this in mind as we start talking about the yields of different diagnostic testing approaches. And so this just shows this diagnostic testing approach a slightly different way. I can minimize this, I apologize. So this is just showing that diagnostic testing platform a variety of different ways, going from the SNP array all the way through to next generation sequencing and targeted single base pair analysis through genome and exome, looking for really those needles in a haystack, so those coding or splice site variants that might be leading to disease. No. So how useful are arrays? And this is something that we're going to talk about a lot today, because this is, like we said, our bread and butter first line test for congenital heart disease. And we know that there are indeed increased copy number variants in de novo copy number variants in individuals with complex congenital heart disease as compared to controls. So if you take a large population of infants or patients with congenital heart disease and you perform microarrays and you just look for new copy number variants, they're enriched in congenital heart disease populations. And previous estimates of how enriched these copy number variants are really vary based on the population that you're looking at. And so in one study of about 400 patients from Boston Children's, they found a diagnostic yield from all comers coming into their lab of microarrays of about 12.8%. This included both pathogenic copy number variants that you would pick up on a microarray and aneuploidies that you would pick up on something like a karyotype, but you can also detect on an array. They also had another 5.8% of patients that had a likely pathogenic copy number variant,
So for all comers, it was about a 17 to 18% diagnostic rate of something that looked pathogenic. And this idea of likely pathogenic or variants of uncertain significance, which have even less evidence than a likely pathogenic copy number variant, doesn't take interpretation. This is where bringing in a clinical geneticist to think through, does this fit with the patient's phenotype make sense? This is manifest even in our discussions today on the chat here, where there's been lots of discussions about these variants of uncertain significance and how you think through those. So it's important to keep in mind, it does take digging a little deeper and thinking through some of these changes. And so this is just showing a wide spectrum of the diagnostic yields of microarrays from a variety of studies. And as you can see, the diagnostic yield spans in that far column from 3% or 2% all the way up to 50% in some populations. And it really has to do with the population that you're looking at. And we know that if you look in populations of patients with a syndromic phenotype, so that have other anomalies, other features on exam, you have a much higher yield of percent. If you compare this directly, this going back to that Boston study, amongst all cases, I said they had about a 14.1% diagnosis rate off a microarray for patients with congenital heart disease. So for all comers, about 14% of this population, they found an answer. But in the patients that just had isolated congenital heart disease, who didn't have other features, that diagnostic rate dropped to 4.3%. So there really is a difference in the clinical utility of a microarray in syndromic versus non-syndromic populations. Now, it should be the first-line test, or in most instances, the first-line tests for patients with complex congenital heart disease. As Elle said, we're moving towards exome sequencing a little bit to cover some of those, to be the first-line test in some cases, and we'll talk through that. But even so, as the first-line test, it can detect a difference in about 14 to 20% of patients. So it's a useful test to have in your repertoire. But we wanted to sort of move beyond that and think what adds value to a clinical diagnosis or a clinical genetics evaluation beyond just a microarray. And so I'm going to focus really on 3 questions for the rest of this talk. And the first is really, how useful is a clinical genetics evaluation in infants with clinical congenital heart disease? And I'll be talking about a study that we did a number of years ago now, trying to get at that question. So when you add everything together, not just the diagnostic testing, but the clinical evaluation by a trained geneticist, what's your yield? And then we'll move on to the newer technologies that people are now using at our institution and a lot of other institutions. So both exome and genome sequencing, and we'll be talking about how that increases the likelihood of a diagnosis. And then making finally some comparisons to genetics evaluations in infants with other critical infantile heart disease, such as cardiomyopathy. We have a very large population actually of infantile cardiomyopathy at our center. So we had a chance to sort of explore how these approaches can be applied to similar disorders and similar groups of patients, and sometimes overlapping in terms of their molecular diagnosis, as we spoke about earlier today. So first, we'll talk about how useful is a clinical genetics evaluation. So this is a study that we did a number of years ago, like I said, and it really had 3 questions that we were trying to answer. So the first is, what is the diagnostic yield of a clinical genetics evaluation in infants with congenital heart disease in a cardiac intensive care unit? And what features predict the likelihood of finding a diagnosis? So if you're going to have a clinical geneticist come see your patient, what features of that patient are associated with a higher likelihood of finding an answer? And then what testing was useful? So this is important to remember. This is an older study that really is in the era before exome sequencing. So this sort of gives a standardized approach, or a standardized evaluation, at least of our center's approach, before implementation of exome. We then have gone on to start thinking about what changes since we've started using exome, and we'll talk about some of those features. But unfortunately, exome sequencing isn't available everywhere around the world at this point. So I think it's important to think about the diagnostic yield with exome and without exome. So the study design for this first part of this talk was basically a retrospective review of every infant seen by the Clinical Genetics Service in our CICU over a 5 to 6 year period, again, a while ago now. The records reviewed include all prenatal records, the initial genetics consult note, and then also, importantly, all the results from all the other investigations recommended by genetics. And I think this is something important to think about. When we go see a patient, whether it be in an ICU or an outpatient setting, we have associations in our mind as we see a patient to say, oh, if we could look at the eyes or if we could look at the kidneys, this is going to give us more information about the likelihood of a specific diagnosis. So it's not just genetic testing that we're sending, but it's really full phenotyping that's really important to make a diagnosis in a patient. And that phenotyping of an individual often requires other subspecialty evaluations, whether that be looking, like I said, the eyes or hearing or the kidneys or anything else. And those pieces of information sometimes are just as important or equally important as the genetic testing results. And then finally, all of the cardiac records, which are clearly important when thinking about infants with congenital heart disease. So our study population, you had to have been admitted to the CHOP cardiac intensive care unit at less than a year of age, and you had to obviously have documented congenital heart disease. I think it's important to remember some caveats about our study population. So as I was saying, genetics consults were initiated at the request of the CICU team. So this is important because now we have tried to also implement a standardized approach where everybody with congenital heart disease is seen by our clinical geneticists. In general, a very high percentage of our system is seen, or high percentage of our patients are seen by clinical genetics. But until you protocolize it, you don't know that that's what's actually happening. Non-dysmorphic infants with cardiomyopathy are not included in this analysis. So this is really focusing on structural heart defects. And then unstable, very premature infants would not be included in this because they actually go to our neonatal intensive care unit. So if an infant was born before 35 weeks of age, usually they're not going to be included in this study. But that's a very small proportion of our patients. So we had 364 patients. They were pretty well sex matched. They came from a variety of races. Their mean age of admission was 0.4 months essentially. And the genetics consultation usually happened in our center at the first day or two that they were in our center. So it happens very quickly. Almost everyone had prenatal echoes in our population, which I think is also a very interesting feature and might be regionally and internationally dependent on your accessibility to prenatal echoes. And prenatal genetic testing was very common in our population. Postnatal genetic testing was sent on a lot of patients, and then we had a wide variety of different cardiac diagnoses. Overall, of the 364 patients evaluated, we found an answer about 25% of the time. So very similar to the data that Elle was presenting from their experience. And I imagine if we protocolize this, we could actually increase, or we have increased our yields. And so 8.5% of our cohort was actually diagnosed prenatally, which tells you a little bit about our demographics and our diagnostic approach in our area geographically. And then 16% were diagnosed postnatally as a direct result of the initial genetics consultation. So here's our genetic diagnostic rate by lesion, which is not surprising. And I think that we should keep in mind. So our patients with septal or AV canal defects had a much higher diagnosis rate, and this did include infants with trisomy 21. So a number of those kids had trisomy 21. I think it's interesting to see that patients with right-sided obstructed lesions had a much lower diagnosis rate of our standard genetic approach. And this is just showing it both as a figure and an odds ratio. So if you zoom in on our biggest population of defects, or our conal truncal defects, you are able to see which specific conal truncal defects had higher diagnosis likelihoods. And again, some of this has to do with a number of the syndromes we've already spoken about today, such as the interrupted aortic arch. I hope you remember and keep in your mind that in interrupted aortic arch, you should have a very high suspicion for 22q11 microdeletion syndrome. And in fact, most of those patients in our cohort did have 22q. I should say that we're also a big referral center for 22q11 microdeletion syndrome, so we probably have an overrepresentation of that population in our center. Again, also tetralogy of Fallot was associated with a higher likelihood of diagnosis. So common diagnosis by lesion, I've alluded to some of these, but AV canals, most of them were trisomy 21. Conal truncal defects, a lot of them were 22q11 microdeletion syndrome. But interesting, our septal defects, all 9 that were diagnosed in our center had a different diagnosis. So there's a lot of variability in things that can lead to septal defects. Now, this is what I think is important and sort of highlights some of what's already been discussed today. And we really need to work on developing new ways of figuring out how to help people identify dysmorphic facial features, because you can look here that the presence of dysmorphic facial features was one of the biggest features that really helped predict a higher likelihood of having a genetic diagnosis. So making tools available, like I was speaking about, to be able to identify these features is really important in helping to figure out which infants really could benefit from a thorough genetics evaluation, even if it's a limited resource in your center. So what are the diagnoses? And this is showing you both prenatally and postnatally. So prenatally, you have to remember that the vast majority of the patients that were diagnosed prenatally had either a karyotype or a microarray or both. They did not, at this point in time, have a lot of targeted gene testing. And so the diagnoses that were picked up made sense that you could pick them up on a karyotype or a microarray. So trisomy 21, Turner syndrome, as we spoke about, 22q, and then other copy number variants. Postnatally, you start to pick up a lot of those other disorders that have diagnostic facial features, for example, that you can see in a postnatal infant, things like Charge and Noonan and some of the other disorders that we'll talk about a little more. And so then diagnostic yield by test, and these again using a lot of the standard sort of older first-line tests that we've used. So karyotype was diagnostic in 23% of individuals. Microarray in our hands was about 9% diagnostic rate. But we also had additionally 25 arrays that had VUSs. So again, this idea of having to go through variants of uncertain significance and think about whether or not they're pathogenic. And there's a lot of features of a variant of uncertain significance, both on a microarray or on any sort of next generation sequencing type test that you can think about, including some of the things we were talking about on the chat today. Was this change inherited from an unaffected parent, or is it new in the individual? How common is it in the population? Those types of features can help you start thinking about these variants. Okay, so just to take one moment to go through some of the copy number variants that were detected prenatally. So by far the most common in our hands was 22q11. Again, postnatally, 22q. But you can also see some of the other pathogenic copy number variants, some of which on 8p23.1, which is important to think about because that's where GATA4 is located, a transcription factor that's really important for patterning of the heart. We also saw a Creta-Schott patient, Kleefstra, Williams, as we spoke about. So there's a variety of microdeletion syndromes that can be picked up through microarray. And I'm not going to spend too much time on this, but I at least wanted to highlight and remind everybody so you can take away the key features of the most common diagnoses that we saw. So the most common microdeletion we saw was 22q11. We've had beautiful discussions of 22q11 microdeletion syndrome. So you have to remember it's not just a cardiac lesion, that there's a variety of parts of the body that are very affected, including the brain, the craniofacial area, the palate. You can have thymus dysfunction, immune system dysfunction, hematologic dysfunction. There's a lot of organ systems and a lot of integrated care that needs to happen. And just showing you again what's already been highlighted, that the facial features of 22q11 microdeletion syndrome change, but with both ethnicity and age. And so having some help in terms of finding the facial features can be helpful. But just to sort of keep an eye out of some major facial features that you can sort of look at for 22q, this idea of this asymmetric crying face. This little boy in D is clearly not crying, but he has an asymmetric smile. You can see a lot in the eyes in terms of both an upslanting and a hooding of the eyes. And also the ears are often a crucial spot that we look at. So there's some nice reviews out there showing you some of the basic facial features that I think familiarizing yourself with just a little bit so that you have that pattern recognition of some of the facial features plus diagnostic or common cardiac lesions, such as an interrupted aortic arch, should raise your red flag that maybe I should think about 22q. And we talked a lot about the cardiac lesions of this disorder already. So then pathogenic variants that were detected. So these are some of those single nucleotide or a few nucleotide changes that are picked up through next generation sequencing, either using targeted gene sequencing, a multi-gene panel, or nowadays through exome. And the most common postnatal diagnosis that we had with a single gene mutation disorder was Charge syndrome, which we have not talked about today. So I'm going to take 2 seconds to speak about Charge. Charge is actually an acronym that stands for coloboma, heart disease, choanal atresia, growth issues, genital urinary anomalies, and ear anomalies. And you can see some of the facial features of Charge shown here, including you can often see signs of a repaired cleft because a lot have cleft lip and palate. a broad forehead, and again, the ears are very characteristic for CHARGE syndrome, similar to 22q, where the ears give you a lot of clues into these patients. In terms of the cardio, and like a lot of the other syndromic diagnoses we've talked about, there are obviously a lot of organ systems involved, and these kids require multidisciplinary follow-up. And the cardiovascular malformations that are associated with CHARGE tend to be either conotruncal anomalies or AV canals or aortic arch anomalies. So this is just another one to keep sort of in the back of your mind, and it was the one that we saw the most common in our population in terms of single gene disorders. So the conclusions of this first part is really that clinical genetics evaluations of infants with clinical congenital heart disease in the CICU yielded a diagnosis about 25% of the time. And then patients with AV canals and septal defects are more likely to be diagnosed. And diagnostic yields are 4 times higher in patients with dysmorphic features. So the clinical genetics exams really are important.
Presentation. Thanks to the speakers and Dr. Agati and all participants. The poll.
Yes. Can you stop the share, Rebecca? Yeah. Thank you.
I can try to stop the share.
Yes.
There we go.
Thank you very much. I think that there will be a lot of questions. My idea, if you are okay, we can leave open for a few minutes the chat rather than to go with the poll, or we can try 1 or 2 polls for each, because I saw that in the chat there is a lot of movements, and I think that we can give opportunity. I saw that Gabrielle is giving the email, Anwar is doing the same. I think that this was the starting events about cardiogenetics, and I'm sure we start from the right way, because the approach must come completely from cardiogenic side, from genetics, completely from pediatric cardiology, and trying to keep the experience together according to what I think is very important is the clinical impact of each genetic disorders for all the patients who are going. Of course, as cardiac surgeon, we are very, I told you before in the broadcast, very interested about this. So I think that this was amazing. It's not the right word, it's more than amazing, because we have a lot of people from around the world. During the preparation of this webinar, we met people from Africa, from other countries, where these things, the diagnosis is not still possible. So Congenital Heart Academy wants to try to keep, as you say, and also Gabrielle say about the fact that you can make an application how the people can have diagnostic suspicion of some genetic disorders. At the same time, I think that is very important that, as you say, we have a bit to change the language of genetics, and we have to change a bit the approach of the clinicians. They must work more together, trying to keep the same language that is not easy. So this is my. I know, Gabrielle, we talk about this, and this was the starting point. And when we found the experience from Rebecca, we said that this can come, of course, in clinical, must come in clinical practice. And at the same time, we discussed with Grace, we have a very big group of researchers in a Congenital Heart Academy. There are people interested in research, and I'm sure that, of course, we cannot think to do a perfect genetic test to child from Africa or different country, but we can start to help sharing what do we do when the genetic syndrome is confirmed. And Anwar, in Rome, we are using a protocol for antibiotics according to what is the main diagnosis of the genetic disorder. So again, there is a lot of things. I'm sure this was the first step in a good way. And we have some delegates from, one is Gopi Nalayan from India. Question. there is our delegates from the Gulf. That I don't know. She has to ask something. Are you okay?
Very much for such an interesting presentation. My question goes to Rebecca at the end for prenatal diagnosis. Now, if you go for prenatal genetic testing, what will be the test asked for? I didn't get this quietly. Is it microarray and chromosomes, or this is the standard? What about the other ones, like if we do NIPT and you want extended NIPT, what do we tell the parents? Because I'm a pediatric and fetal cardiologist, so what will I ask for if I find a congenital heart disease in general? It doesn't have to be a truncus or a VSD or anything. What test do I ask for, and how valuable this test, and what's the relation to this available test to the NIPT? Thank you.
Yeah, so it's a good question. So I'm not sure if everyone's familiar with NIPT that she's referring to. So NIPT, or cell-free DNA-based testing, was developed originally to look using a blood spot or a blood draw from the mother for circulating fragments of DNA from the fetus to look for aneuploidy. So to look for trisomies 21, 18, and 13. Some companies are now calling off microdeletion syndromes from that sample. So it really depends on the laboratory you're using and the validity of the testing for different things that they call off. So some samples or some companies are calling off 22q pretty regularly, and that tends to be the one that's the most commonly called off from NIPT testing. And some are doing even more than that in terms of microdeletions. So you have to look at the fine print of the NIPT company that you're using. Now, a diagnostic test would have to come through either a CVS, a choroid villus sampling, or an amniocentesis. And you have samples that you can then do further diagnostic testing off of. And again, you can do a karyotype, a microarray, or targeted gene sequencing now for known genetic changes. So for example, if we have an infant that we suspect has Noonan syndrome, we will send a multi-gene Noonan panel off of that testing. And what I didn't get to talk to a little bit in our talk today, because we ran out of time, is that there's now a push to doing some degree of exome sequencing, mostly in a research setting, but it's moving towards a clinical setting off of those samples from infants that identify, or fetuses identified in utero to have congenital heart disease or other defects.
In utero, the ones you've done, the prenatal genetic testing, what did you do? Was it fetal DNA, or was it amnio and CVS? What was it?
Yeah, so we try to really go with amniocentesis or CVS-based testing and using microarray and then targeted gene sequencing for things that we're suspicious of, or if there's a known family history and the family hasn't chosen to do pre-implantation testing. So that those are diagnostic tests. That being said, a lot of families choose not to do that.
Thank you.
Excuse me.
No, wait. Samak.
Yeah.
Samak.
Okay.
Sorry, wait a moment. We have Gopinala. You already used your time. Wait a moment. Sorry. We have one colleague from India, and
I would like to tell. I would like to tell about the detection of the deletion in the cell-free DNA, according to the lecture of the professor.
Gopi.
Yeah.
Yes.
Yeah, good evening. It was a very nice presentation by Rebecca, Gabriela, and Anwar. I have learned a lot from you all, because as a surgeon, we are almost interested in genetics, because post-operative care mostly depend upon the genetic, as you told, the post-operative ventilation time and response. So it's nice initiative by Sasa and Grace through the Congenital Heart Academy to bring us together, and so that we can mingle with each other and do good to the patients, to the society, and improve the results of the patient care. It's a very nice presentation. Thank you.
Thank you very much. So, Professor, now it's your moment. Hello? Samak.
Yes.
Sorry.
Yes, sorry to disrupt. I would like to tell you, NIPT test it's useful, but only for with high accuracy for 21 trisomy. As you know, 18 trisomy 18, trisomy 30, the accuracy is less than 21. On the other hand, if we would like to check other deletion duplication by NIPT, the accuracy is less than 60%. So, as the professor told us, it's better to do amniocentesis and check by the array. But it's very important during the first trimester, 11 to 13, according to the diagram, check the NT. Most of the country, if the nuchal to more than 2.5 centimeter, but in other country 3 centimeter is very it should be very accurate. So I would like to tell you NIPT it's not correct way to detection any congenital heart disorder.
Thank you very much. There is some comments, Anwar.
I just wanted to say quickly, sorry, that I put a link in the comments section. The National Institutes of Health has a genetics in diverse populations project that's run by a cardiovascular geneticist, Dr. Max Minke. And I don't actually know his current funding situation or what he's doing, but he's specifically interested in expanding our genetics knowledge in populations that don't have resources, that we haven't had great representation from before. So he might be someone for those of the attendees who are asking for research contacts. I think he might be a really good one to look up.
Yes, thank you, Gabriela.
It's okay if we share in our social media this information, or we should talk to him before?
We should probably email him first, but I'm sure he wouldn't mind.
Spread the news. This is something that would be helpful for a lot of people. Okay.
Yeah. Rebecca, you want to say something?
Oh, I was just going to second that. I think that's a great resource. And also going back to the NIPT, I think it's important to remember it's a screening test. It's a very good screening test for certain things like trisomy 21, but it's not a diagnostic test. And so we harp on that a little bit as geneticists, and we really believe that getting a sample from an amnio or a CVS or postnatally is really what is going to make the diagnosis. And it's important to read the fine print of any test, but especially NIPT, because its accuracy varies a lot by diagnosis.
Sasha,
so now we can say, sorry.
Oh. I just want to answer Rebecca. I mean, as fetal cardiologists and as cardiologists, obstetricians, they all know that NIPT is screening and they have to do other things. But now what's coming up in the market is the FISH, and they're trying to do better and better. So do you believe in the accuracy of the FISH one, the extended NIPT, looking for the FISH, which is 22q, or as geneticists, you doubt what's going on?
I think it's not a perfect test. I think we need much larger populations to show the true accuracy and much more experience using these test modalities. And again, it is all to some degree computationally derived from a sample that you're trying to purify from mom. And so it's important to remember that testing the primary tissue from the infant is important.
Thank you.
Okay, so I think that we are done. We spend more. Grace will kill us because it was very out of limits, but science doesn't have, that science doesn't have limits of time, no problem.
It was really amazing. It was worth listening to all of you. Thank you very, very much. We really appreciate.
Okay, so bye from Italy and to all of us, please. From Rome.
Bye, bye.
Hi, Gabriel, thank you. So the promise, we finish with the promise. We can make a research on this field together. we will launch in our delegates with Gopi also in India. We will try to do our best, and I hope you will coordinate with Anwar, with all the
Yes,
stuff.
of course.
I know that it's not easy, but at least we try.
We can try. We must try.
Yeah, and if Grace is around, you are in trouble because she can send you 100 email in 1 hour. So no problem. That's good. I thanks the Dr. Sab.